We'll start our oral in-person presentation, track 2. I would like to introduce our judges. Dr. Karunakaran Madhiharan, he is a former professor of forensic pathology and expert in legal medicine. And Dr. Arun Rachna, he is a professor and head of Psychiatry Unit 3. I would request them to please take this. I would like to hand over the session to the moderators.
Today afternoon for some of the very interesting papers who worked among the community, and let us all listen to them. We can start.
So, good afternoon, everyone. I'm Gauri Nandan Saikia. I am from Assam, and I'm representing here one of the projects called Saksham. And my institution is Piramal Swasthya Management and Research Institute. So, my topic of today's presentation is community-led solutions for child health, a community-based participatory research approach in tea gardens of Jorhat. So, Jorhat is a place in the state of Assam. So when we talk about Assam, Assam is called the tea capital of India. It accounts for almost 700 million kgs of tea production, which is half of total India's production. We have around 800 large tea gardens and more than 1 lakh small tea gardens. So these small tea gardens belong to individuals, while these large tea gardens are run by companies and individuals as well. So before we go into the problems, before we actually discuss here why we have chosen to work with this tea garden community, we need to understand the history of this community. So Britishers in 1820s, 1830s were looking for an alternative for China's monopoly of over tea business in the entire world. So they came to know that Assamese people are drinking some beverage which is very much similar to the one that has been sold everywhere by China. So in 1823, it was confirmed that this is tea, which has been, where China had the monopoly at that time. And after a struggle of almost for 10, 15 years, commercial production of tea has started in Assam. But the problem was cheap labor. We needed a lot of labor to make it a commercial product to fight with China. At the same time, the Chota Nagpur area, which is comprises of modern day Chhattisgarh, Orissa, Bihar, Jharkhand, and West Bengal, there was a revolt against the Britishers. So Britishers thought of a plan. We all know how intelligent the Britishers were. So they thought of a plan to tackle both these issues. So they started bringing these people forcefully from these areas to Assam as a bonded laborer. And these people were taken to these places in a very unhygienic conditions and without any facilities. So if you look at the next part, till 1947, batches of people had kept on coming to Assam, and there was a very minimal facilities being provided in respect to health and other facilities as well. Only after independence in 1951, a Labor Plantation Act was passed. And from there, government has taken few initiatives. So the problem with this tea garden is they are supposed to have healthcare units. They're supposed to have healthcare facilities. But you'll be surprised to know that this healthcare facilities does not fall under health department. It falls under labor department. It's same with the rubber plantation, tea plantation, coffee plantation as well. So the problem becomes, what we understood is to run a health facility, you need certain competencies, which is lacking at the department level as well as at the tea garden management level. So uptake of this particular schemes or the facilities that has been provided with to the tea garden community is very, very low. So reason for this is, as I mentioned, the people who we call tea community is actually belong to a place called Chota Nagpur, Chhattisgarh, Orissa, this side. And they reside in a very close setting. These people reside within these tea gardens, 800 big tea gardens, and they have very minimal connection with the outside world. Also their traditional beliefs, the practices, the working conditions, and kind of rules that's been set for these tea garden workers makes it very difficult for them to access healthcare facilities that is available outside the tea garden areas. So I'll just give you one example of the way they function. Britishers started this policy. I think all of us will know that, early morning, the walk needs to start. Today, if you go at 6 o'clock to the tea garden offices starts at 6 o'clock in the morning. So they are still continuing with the same habits. They are still continuing the same procedures that Britishers followed. Only thing that is not been upgraded is the healthcare facilities or the other facilities that has been provided to these people. So to address these issues, actually, we have a program called Saksham, which is being funded by USAID. And it's a consortium that we are working in. So our responsibility is to address these community level issues. So while addressing these community level issues, we need to demonstrate it to government and to the community and to our donors as well. And then we need to work with government to scale this up to the other geographies with similar conditions. So to address this health inequalities or disparities in these tea garden areas, we have adapted this community participatory research approach, and where we have worked with the community very closely for last 2 years. The first half of it was very tough for us. So you can see some of the glimpses from the tea garden areas on the left-hand corner. It's a beautiful tea garden, and then some of the photos, which is very self-explanatory. So while we have adopted these 3-step procedures where we decided to work with the community, we had to identify this community in consultation with these communities. So as I mentioned, first 6 months, it took us just to get into the community and understand what will work, what will not work. Then the workshops, of course, and identifying the health issues. So in child health, we have identified some major issues which need to have community level interventions, or the community needs to participate in this. So one of them was diarrhea, and then of course pneumonia and other health issues. So we have focused on the diarrhea part, also the pneumonia part, but today we will discuss mostly about the diarrhea thing. So then collaborative activities by community groups. Of course, we'll explain this further in our next slides. So we used community-centric design where we use the community's close need and nature and respect for the leaders as one of our investments. And also we have focused on male participation, because male are the decision makers in the tea garden communities, where they had very minimal participation in the healthcare issues. So if you look at the findings, this was the formats, the tools, everything was co-designed with the community. And we all know almost most of the areas in tea gardens have been declared as open defecation free areas. But from the community, it had came out that we have reached out to around 7,000 households in one district, and 21% of them were still, like having open defecation. So if we talk about the problems that why they're still doing it, so if you will just take one example here, open defecation. So usable toilet, which is built by government department, 8%, access of water 38%, behavioral 39%. Just one more minute, please. And financial issues 6%. So I will quickly talk about the results here. So this has led to identifying 3 key health issues and the need to work with the community. Community action, of course, and improvement in knowledge and practices level. But the major thing that I have mentioned in the bottom part, I think we should focus on that. So we could form these core community groups. Memorandum to the district authorities has been presented. District task force was formed in the government, and multi-stakeholder forum was formed by government to respond to these issues. I will conclude here. Thank you.
Any questions from the audience? Nothing on the chat.
Are you still continuing this work?
Yes, sir. We are continuing. So we will be moving into the other districts now, sir. We have a government buying for this.
What is the time frame when you started?
So 2025 September.
So for the past 3 years, you have been continuing.
We have been doing it for last 2 years, sir. This is our second year of our intervention.
How long you will be continuing this process?
So, sir, the idea is to continue it for 1 more year and then hand it over to government. So Yeah.
What is the age group of this?
The community leaders you are talking about, sir, we have included all age groups here. So this is how we have done it, sir. This is a nomination basis. So we have formed core groups within the community. We had multiple rounds of consultation with them, sitting with them, and understanding who other people can be the people whom we can disseminate the messages which we will talk about. Yeah.
Thank you.
Thank you.
Thank you, sir. Thank you.
Mr. Muhammed, Thareekh.
Good afternoon all. I am talking about the topic, Aging and the Social Compact in Kerala, a pilot study of a novel initiative of neighborhood groups for elderly. Background. According to the 2011 census, 1 out of 8 individuals in Kerala were aged 60 or above. This changing demographic condition poses challenges to the state as there is a transformation in family structure with the migration of younger family members. Consequently, aging individuals rely on family and immediate social network for support. Changing social compact. A social compact can be considered as something that gives expression to and is based on reciprocal ties that holds families, governance, and society together over time. It thus includes a shared vision, shared values, and a sound economy that commits to supporting a good quality of life for the members of society. Intergenerational exchange of resources from one group to another continues to happen mainly at the family level. However, the family as a basic compact for caring for and supporting the elderly is strained. Critical needs like quality of life of the elderly can be met by strengthening the social compact. Age-friendly Panchayat. The Social Justice Department of Kerala State in 2013 launched an age-friendly Panchayat initiative to improve senior citizens' health, social participation, and quality of life. In line with this, recently a neighborhood group initiative has also been launched in some panchayats to support senior citizens. This pilot study assesses a recently launched neighborhood group initiative to support senior citizens in Manikal and Pullampara panchayats, Thiruvananthapuram district, Kerala. We consider this a pilot study and propose expanding the study to other local governments based on the preliminary findings. Methods. The interviews were part of the preparatory work with Manikal and Pullampara panchayats for an MPH dissertation on knowledge, attitude, and practice regarding Ayushman Bharat Karunya Arogya Suraksha Paddhati among elderly persons. The study intends to select participants from the neighborhood groups in these panchayats. The study and the non-governmental organization, that is Health Action by People, play pivotal roles in the establishment and functioning of these groups. The study received clearance from the Institutional Ethics Committee of the University of Hyderabad. Methods. We conducted four freewheeling interviews with elderly persons as part of the formative assessment towards the study. After that, we conducted 6 semi-structured interviews with key informants from the panchayats and a non-governmental organization, that is HAP, Health Action by People, working in this area on factors related to the formation and functioning of neighborhood groups and active participation of the elderly. At present, we have made non-verbatim summary transcripts. We did inductive coding of this and plan to expand this into a more extensive study. Findings. The program started in Venganur Panchayat in March 2021 with the aim of to improve the quality of life of elderly. Idea generation, training, human resource, interventions, and all are these factors that are included in this program. Initially, there will be a problem mapping, which almost all panchayats are aware of the problems faced by their senior citizens. And the next level, it would be resource mapping. First, once the problem is identified, then we will map the resources within that local government. For every panchayat, there will be a mandatory allocation of 5% funds for elderly welfare. This is used for, usually this is used for passive instrumental support and not for active empowerment. There are other resources, including financial and that are non-financial. The implementation level, these resources, once the problem is mapped and resources are mapped, then we will implement it through these neighborhood groups. Findings. Beneficiaries. Persons 60 years of age or above, they are categorized into 3. That is type A, who are bedridden, type B, who are homebound, type C, who are independent and mobile. Each neighborhood consists of nearly 20 to 25 people in size. Neighborhood groups, that is a 3-tiered structure with at the panchayat level committee at the head, ward level committee in the middle, and electoral ward and the neighborhood groups. Findings. Who compromises the social compact? 3-tiered structures of neighborhood groups. Each neighborhood group have 5 members who are chosen as volunteers to whom training would be provided. At the ward level, there would be ASHA worker, Anganwadi worker, ward member, who is an elected representative, Kudumbashri, which is the Women Self-Help Group for Livelihoods, and Area Development Society chairperson. At the panchayat level, local self-government representatives, members of senior citizen associations, Kudumbashri Community Development Society chairperson, health department, that is medical officer, and police station house officer. Other departments and volunteers would also help this three-tiered structure. Findings. Health interventions, monitoring of blood pressure and blood sugar, discussions on fall prevention, dementia, physical activity, yoga, etc. And there will be regular and frequent medical camps for elderly. Income generation activities in early stages are taking place in these neighborhood groups, such as candle making, paper bag making, etc. Challenges in keeping the elderly motivated to participate in neighborhood groups due to lack of immediate financial benefits, difficulty in distinguishing the neighborhood group initiative from the current measures, diversity of needs and political tensions, which all are these challenges including in this initiative. LSGs can bring in leadership with flexibility. Key Informant 3 says, it is easy to recruit youth and middle-aged people, convincing them that today's youth is tomorrow's older adults. Key Informant 2 says, we try to ensure the well-functioning of the neighborhood group initiative to an extent where unused funds from ICDS are also utilized for elderly welfare. Having a champion helps. Whenever we slow down, HAB gives us the push to run again. In a nearby panchayat, the medical officer solely carry out the activities like yoga for the elderly. Shared vision. Without involving senior citizens, comprehensive development is not possible. Everyone should think there is a need to look after the elderly, and they should think that they will be future older adults. Reciprocal ties. We did not get clear evidence. A YouTube channel on cooking traditional recipes may help intergenerational ties. Discussion. The neighborhood group model for improving the quality of life of the elderly is in a very early phase. The interest of at least one of the discussion conclusion, although in its early stages, the recent neighborhood group-based initiative for elderly is a potential platform for addressing social determinants related to healthy aging. Thank you.
Any questions? Any questions in the chat box? There's already existing social compact in the community, no? How do you differentiate your initiative from the pre-existing?
Sir, actually, as there is migration from the part of youth, the elderly welfare is very much in constraint. So we should come up with neighborhood groups, which is already successfully running in case of women like that of Kudumbashri. So it would help to understand what all are their problems. They could come up with their own problems. For a comprehensive development of the society, and considering their problems also matters.
Did you get enough cooperation from the community?
Sorry, sir.
Did you get any cooperation from the community?
Cooperation. Yes, sir.
Everybody involved themselves.
These neighborhood groups, I focused only on the people who were in the neighborhood groups. This is this early phase of this is a large study. So we are contacting the elderly within this neighborhood groups, and they are actively participating. They are telling about their experiences in this neighborhood group.
Thank you. Mayur.
Good afternoon, everyone. The topic is accessibility, affordability, and cost benefit for seeking healthcare for chronic diseases through community-owned Kiran clinics in Wardha. Just talking about the background, innovations in providing primary healthcare at the village level by engaging community members have been tried or attempted worldwide. One such initiative is Kiran Clinic, which is the community-owned Kiran Clinic, a community-owned primary healthcare clinics by the Department of Community Medicine, MGMS Wardha. It was initiated as part of the community-led initiatives for child survival program in 2003 and 4. While conducting community health needs assessment, the communities expressed their views of providing primary healthcare, or in the villages where primary healthcare government systems were not functioning or defunct, they expressed the need of such community healthcare clinics by providing doctors once a week. And that's how the community ownership came forward, and it was a social franchisee approach. The franchisor was the Department of Community Medicine, and the franchisee was the village coordination committee that was formed during the CLICS program. Voluntary participation, community dialogue, capacity building, transparency, and quality are the pillars of Kiran clinics. With increasing burden of non-communicable diseases, there's an urgent need for improving awareness, healthcare seeking among underprivileged and vulnerable population. And that's where we need to strengthen primary care at the community level by engaging the communities. And hence, Kiran clinics provide a socially acceptable, feasible, and sustainable model. As we can see from the picture, the left uppermost picture is one of the first Kiran clinics which was started in Wardha. We conduct these community-owned Kiran clinics in Anganwadi centers or the Gram Panchayat offices. We can see how the community health volunteers or community members are involved in the process of patient registration, also managing the entire finances of the Kiran clinic. Like if the patient pays the registration fees and the medicine cost, everything is being managed by the community volunteers. The objective of this study was to assess cost effectiveness of Kiran clinics for providing care for hypertension and diabetes compared to other health facilities, which are either the government health facilities or private hospitals, to understand the ease of accessibility and affordability for seeking care for hypertension and diabetes in Kiran clinics compared to other health facilities. It was an analytical cross-sectional study conducted in the month of October 2023 in the field practice area of Department of Community Medicine, MGMS Sevagram. The study population was patients diagnosed with hypertension and diabetes in the field practice area with 28.5% prevalence of at least one NCD from a study conducted in India and 95% confidence interval with 10% error and design effect of 2. The minimum sample size needed for the study was 157. A semi-structured questionnaire for assessing accessibility, affordability, and calculation of direct and indirect cost were the study tools. And the data analysis was done using R program and Jamovi. Talking about the results, around 58% were males, 42% were females. A majority of population, the patients were either illiterate or having primary or secondary education. A majority of the patients were either unemployed or farming as the occupation. The type of family was categorized as one generation where only the elderly couples were staying, or elderly couples with their children or with their grandchildren as 3 generations. Around 50% were having APL ration card, and around 50% were having BPL ration card. Sevagram also provides health insurance to to people in Wardha, wherein they have affordable healthcare in the hospital setup in the tertiary hospitals, which was like 50% cost cutting is done at the hospital level. The entire samples in the entire sample size, around 75% were diagnosed with hypertension, 10% with diabetes, and 14% were having comorbidities. 47% were accessing care in Kiran clinic, 27%. So it was purpose and sapling that was adopted in the study, when 50% patients were taken up from the Kiran clinics and 50% from the other health facilities. And out of those 50%, around 28% were seeking care from the government health facilities and 23% were seeking care from the private hospitals. So for patients seeking care in Kiran clinic, they don't have to travel much distances because the clinics are already there in the communities. For patients seeking care in government health facilities, around 6.5 kilometers distance is travel, whereas for seeking care in private hospitals, around 18 kilometers have to be traveled for the patients. The consultation time was 40 minutes in Kiran clinics, 90 minutes in government health facility, and 240 minutes in the private hospitals. The consultation time was calculated as the time taken from door to door, like the moment the patient leaves his house till the time he comes back to his home was taken as a consultation time, and a significant difference was found. When you talk about the doctor availability, there was no significant difference found because Kiran clinic happens once a week. There was shortage of doctors in the government health facilities. That's why we find some doctor availability problem in the government health facilities. And also private health facilities also face doctor availability problem sometimes. When you talk about delay in accessing medicines, there was not much delay in accessing medicines Kiran clinic, but some delay was observed because these clinics take once a week. Government health facilities face shortage of medicines over a frequent period of time. That's how some delay was there. When talking about the private hospitals, the delay in accessing medicines was due to the cost for the patients because they were not affordable. Delay in accessing medicines, there was some delay in the Kiran clinic, government health facilities, as well as private. And when compared to the appointment with doctor, there was almost 30% delay in appointment with doctor in the private setups. When talking about the cost analysis, the total cost was calculated as the consultation cost, the medicine cost. The indirect cost was calculated as the travel cost, the meal cost that they might incur when seeking care in the hospitals in private or government facilities, and the travel cost. So the total cost for seeking healthcare for a particular consultation in Kiran clinics was around 40 rupees. For government health facilities, which was 20, which majorly involved the indirect cost, which was the travel cost. And for private, it was around 1,255 rupees for individual consultation, for one consultation. When we talk about the affordability, the Kiran clinics and government health facilities were highly affordable, with government health facilities as highly affordable because Kiran clinic, we give medicines, but at a generic cost, but the private facilities were highly expensive. When you talk about the patient satisfaction, the respectful treatment was majorly in the private and Kiran clinic, but there was some discrepancy found in the government health facilities, with 10% of patients feeling that they were not either respected or disrespected. When talking about the listening, and there was no significant difference found in the listening ability of the doctors, but whereas with respect to receiving information about the disease, Kiran clinic and private hospital, government hospitals were performing much better. So a remarkable difference in affordability between Kiran clinics and private hospitals was found. The travel time and distance is reduced to 0 through community-owned Kiran clinics. Direct cost is slightly higher in Kiran clinics as compared to government hospitals, but it is being covered by the preventive and promotive care that is provided through community-owned Kiran clinics. And further studies are required to assess, whereas with respect to the cost, are we performing much better with respect to preventive and promotive care that is being provided at the community level? And since the introduction of community health officers at the sub-centers, can we also collaborate with the health system to strengthen the provision of NCD care at the community level? Thank you. So a total of 23 Kiran clinics are functioning in the field practice area. So around 23 villages are being catered by the department. The sub-centers have been converted. These Kiran clinics are majorly functional in those areas where sub-centers are quite far away or remotely located villages. They are functioning. Yes.
What about the sustainability of this initiative?
So it has been functioning since 2006-7. So it has been sustainable till now. The entire sustainability model depends on the community owners because they all manage the entire finances and the organization of the clinics. Only technical support is provided by the department. One doctor and one social worker visits them once a week. If the doctors include either a postgraduate student or an intern working in the department, posted in the department.
Laxmi, Ramitha.
Good afternoon, everyone. I'm Laxmi Ramitha, PhD. Good afternoon, everyone. I'm Laxmi Ramitha, PhD scholar in public health from University of Hyderabad. I'm going to present this topic, non-communicable disease risk and healthcare for underprivileged population, a self-reported morbidity study among municipal waste workers in Hyderabad, Telangana. Globally, now non-communicable diseases are the leading cause of death and disability, and around 17 million people are dying before they are 70 years globally, and it is around 6 million annual deaths in India. And NCD risk factors are basically behavioral and metabolic. Behavioral, that is tobacco use and alcohol consumption, and metabolic is raised blood pressure, raised cholesterol, raised blood sugar levels. And when coming to the hypertension, that is raised blood pressure, almost 10% of NCD deaths is attributed to hypertension in India. And when coming to the diabetes, India ranks second in the global diabetes epidemic. And diabetic adults have 2 to 3 times increased risk of having complications such as heart attacks and strokes. And tobacco use, when coming to the behavioral risk factor, it not only affects the general health, it also impacts the oral health as well. From the National Cancer Registry Program Report 2020, it reported like tobacco use has caused almost 27% of all type of cancers in our country. And if timely interventions are not done, these annual deaths are going to be like around 55 million by 2030. So the risk of NCDs is like it's has a wide impact on certain communities or occupational groups. One such occupation group is municipal waste workers. They are usually illiterate. They come from a low socioeconomic background and are from low caste, and they have intergenerational transmission of their work. And with all this stigma and discrimination is also there. And this has a ripple effect on their forthcoming communities or forthcoming generations. So this group experiences a wide range of morbidities because of various hazards that are associated with waste handling. And also they are exposed to risky exposures such as tobacco and alcohol in order to cope up with the stink that is like while they handle waste. So not only this, they also have social inequities in health. So this increases the risk of developing NCDs and associated burden of healthcare. So the objectives for the study was to assess the major NCD risk factors among the municipal waste workers in Hyderabad and assess their self-reported morbidities and healthcare, and also to assess their oral health problems. So a cross-sectional study was conducted among 471 municipal waste workers and working under GHMC, that is Greater Hyderabad Municipal Corporation. Modified WHO STEPS questionnaire was used. The sections on physical and biochemical measurements were not included for the study. Only the questionnaire part was used. And modified WHO oral health questionnaire and assessment form for adults was used. Coming to the results, the socio-demographic variables, we can see more number of female were into this occupation, and the mean age was around 40 years. And coming to the education, around 61% had no formal education, and most of them, that is 82%, were coming from low SC and ST caste, and their average monthly salary was around 20,000 per month. And also they have reported there was no or minimal hike in their salaries even after working in this occupation for many years. And we have found that around 40% were current tobacco users and 35% are alcohol consumers. Coming to the self-reported morbidities, we can see most of them have reported musculoskeletal problems as commonly, followed by 20% have reported having hypertension, and around 9% were having diabetes. And this was about reported hypertension and diabetes. This pie charts, we can see most of them had reported that they have never measured for raised blood pressure or raised blood sugar levels. Coming to the healthcare visits, around 38% had visited any healthcare provider in past 12 months. And this has a statistically significant association between having a formal education and healthcare visits. And coming to dental visit to a dentist, only 25% of them who have reported they're having dental pain had went to a dentist seeking dental care. And when coming to the oral health findings, 56% had poor oral hygiene, and 7 out of this 471 municipal-based workers were having suspected precancerous oral lesions, such as there's a condition called oral submucous fibrosis and leukoplakia and all. And these are the oral cavity findings of the tobacco uses, tobacco uses among these municipal-based workers. We can see the first one is the suspected leukoplakia case. And the second is a case of smoker's melanosis. And the third one, it's a limited mouth opening case, and it's a suspected case of oral submucous fibrosis. And most of them have reported to self-medicate for their minor health problems like body pains and all. And some of them, like around 18%, have reported to use tobacco use to relieve the dental pain. And most of them has reported that whenever they have any health problem, they're unable to visit a healthcare provider because their wages get cut if they're absent for work. There were no periodic health camps at their workplace. Some of them, like around 40%, reported that they were having health camps, but they were not periodic, and only twice or thrice in their during their work tenure they have health camps. And contract sweepers were having this health insurance called Employee State Insurance Corporation, and the permanent workers had GHMC health cards. In spite of having health insurance, they don't know how to avail these services because they are not having formal education. Most of them felt the need that someone has to accompany them to the hospital. And also there was no provision of first aid kits at the workplace. Coming to the discussion, in our findings, we can see that hypertension was around 20%, which is closer to the NFHS 5 findings, that's 22% in India. And tobacco use among the workers was around 40%, which is actually more than the general population. That is 28% as per the global adult tobacco survey finding. And also we can see that more number of municipal-based workers have never went for checking their BP or blood sugar levels, and hence they are at risk of developing the serious complications from this hypertension and diabetes. And there are also no primary oral health care services accessible or available to this community. And precancerous oral lesions are really, this group needs attention. And similar to the study's finding, study in Chennai also reported that education was associated with healthcare utilization. Since they are low paid and have limited access to the health programs and health insurance, it is difficult for them to get any health care at affordable price or see a doctor when they are sick. And also the National Program for Prevention and Control of NCDs have information, education, communication materials. But when coming to addressing this group which is illiterate or having no formal education, there are no adequate IEC materials. And also ensuring equitable access to healthcare is important for such low socioeconomic groups. And also most of the intervention studies have concentrated, example, tobacco cessation studies are concentrated on particular classes and like school children or adolescents kind of groups. And coming to the limitation, the study findings are limited only to GHMC, and there were no confirmatory tests done for those self-reported morbidities, that is hypertension and diabetes. Conclusion. The study highlights the high prevalence of tobacco use and hypertension, but there is less access to healthcare by the municipal-based workers. It is also important to raise awareness of the risk, NCD risk among these workers. So workplace interventions are needed for this group. And also they need awareness to utilize the health insurance. Whether it is an availability or affordability issue, there are no adequate measures or policies in place for addressing their concerns. And periodic health screenings and tobacco cessation counseling and maintaining health records for this group, and any employee grievance redressal mechanism is needed for such occupational groups. And annual camps and also periodic camps are needed for both general and oral health among this group. These were the references. Thank you.
Any observation, queries?
You mean sanitary workers or by waste workers?
Waste workers. So I have not included drainage workers
How do you differentiate waste workers means?
who come under this DHMC. This drainage workers come under Metropolitan Water Sewerage and Supply Board. So I have not included that group.
Only
The sweepers group actually.
sweepers.
Yes.
Are they given any health hazard preventive measures? Any equipment?
Like the
Gloves?
personal protective, no sir. Rarely they use, and even they are provided once in a while.
Are they a permanent worker or contractor?
Both permanent and contract. Contract workers are more in number among this group, and also contract workers are more on the field than the permanent workers.
Age of the group you get.
The mean age, sir,
Mean age.
40 years.
40.
One quick query. Do you have data on women exclusively? Because
And
in your
women.
population, majority were women, no?
Yes, sir.
And what you have presented is under pooled data. Is there anything on women?
I have to
Segregate.
segregate it. So I'm not.
Okay. Sure.
Very insightful paper. Was it possible for you to examine the BMI of any of these workers?
No, sir. Actually, I've done this work during the time of COVID.
Any possibility
I've-
of finding out if any of them have adult malnutrition or situation like that? Because
Yes.
you are quoting them as having diabetes without having actually ever checked the blood sugar,
Yes.
or being hypertensive without actually having checked hypertension. So the conclusions may go completely off the chart if there is no analysis.
Actually, this is a part of my study. So in my forthcoming study,
Grateful,
I'll try to find this
grateful.
hypertension.
Thank you. Thank you.
Yes.
Mabel?
Good afternoon all. My name is Dr. Mabel from Psychiatric Department in CMC Velu. My presentation topic is Psychiatric Daycare Program, Bridging the Gaps in Mental Health Care Equity. So equity in mental health care implies that irrespective of the background, every individual gets a fair opportunity to fulfill their mental and emotional health needs, which includes rehabilitation. That is whatever may be the background, that is a higher, middle or lower socioeconomic status, every individual should get the fair opportunity for psychiatric services. And the psychiatric rehabilitation, it plays an important role in treatment of the persons with severe mental illness. That is restoring the mental health of the person. It is one of the important role in rehabilitation. And Indian Mental Health Care Act 2017, it upholds the right of persons with mental illness to rehabilitation services. That is, this act in 2017 actually supports and defends the right of persons with mental illness. Psychiatric daycare program, it involves persons with severe mental illness attending a facility supervised by mental health professionals and undergoing occasional rehabilitation. It helps persons with severe mental illness return to their regular life in community and helps reducing caregiving strain on family members. So this daycare program actually aids in changing the pattern, that is troublemaking pattern in family to some kind of a yearning member in severe mental ill patients. And it also provides a support system for those with severe mental illness, as well as provide respite to caregivers from caregiving burden. So this daycare program actually helping the family members to reduce their caregiving burden. Here we highlight a model of daycare for those with lower socioeconomic status and our poor family support that ensures the equity of mental health care. So what is equity? Equity is apart from the standardized care that has been given to mental health ill patients, some additional inputs has to be given to them so that their quality of life and social reintegration is actually improved. So that's the equity of mental health care. The daycare program was conducted by Psychosocial Rehabilitation Unit, Department of Psychiatry in CMC Velu. It was run by occupational therapists who took care of day-to-day affairs, and need-based inputs were provided by a team of psychiatrists, psychologists, and mental health nurses. The clients were enlisted based on proximity to the daycare facility, that is how close to the daycare facility in terms of place and time, and presence of chronic psychiatric illness, and presence of any psychiatric disability. That is disability, that's a lack of mental ability in family, social and occupational functioning, and also in need of vocational rehabilitation. And the clients were enrolled free of charge. The program run on weekdays from 8 a.m. to 4:30 p.m. The program structure, it included occasional training, group activities, and leisure activities. Occasional training, actually, it includes preparing the patients for some kind of a skillful craft so that they could be gainfully employed in near future. The activities incorporated concepts of sharing responsibilities, division of labor, and teamwork. Considering the lack of social support, the clients were also provided financial assistance such as food and travel and medical assistance when needed. Financial assistance such as giving food tokens, food allowances, and travel allowances. In recent times, they are getting free bus passes. In such a way, financial assistance are actually provided, and medical assistance by giving concession in medications. We, in data collected, we examined the effect of daycare program on 30 clients which enlisted into it. We observed for the following outcomes. First, treatment adherence, that is how compliant the patient is to the treatment. Second, employment status, whether he is regularly employed or self-employed or irregularly employed. A third one is improvement in clinical condition, that is based on a transdiagnostic clinical global impression scale. So this picture actually shows the participation of the severely mentally ill patients in daycare program, which includes candlelight manufacturing, earring manufacturing using metals and stones, and then manufacturing of coconut shells, and manufacturing of paper bags. Here we are actually channelizing the individual skills of the mentally ill patients into some kind of social skills so that they could be reintegrated easily into the society. And findings and outcome, the mean age at enlistment to daycare is 34.3 years, in which 83.3% are males and 16.7% are females. 56.7% are diagnosed with the psychosis, in which 26.7% are diagnosed with intellectual disability. In treatment and follow-up adherence, it was found that 60% had regular adherence to daycare program and 40% had irregular adherence. And 6 clients had more than one psychiatric diagnosis. And the medical comorbidities were also present in 4 clients, like seizure disorder, cerebral palsy, hearing impairment, and diabetes mellitus. So after enrollment, it was found that 26.7% were regularly employed in other settings, 16.7% are self-employed, and 6.7% had irregular in their jobs. And 53.3% of patients had a severe illness, and 46.7% of patients had less severe illness. After enrollment in daycare program, 86.7% had improvement in their clinical conditions, whereas 13.3% of patients had no improvement or worsening, and half of the clients were able to achieve some form of gainful employment. The available family members of the clients reported they could engage in other responsibilities. Their caregiving burden seemed to have reduced. The clients were facilitated to obtain social welfare benefits. As intended, the program helped rehabilitate persons with severe mental illness. The rehabilitation services was accessible to clientele belonging to low socioeconomic status. Thus, equity in healthcare was ensured. The program helped with ensuring better treatment adherence and providing support to the clients with chronic mental illness. The time structure of the daycare program was such that it helped clients get accustomed to their routine work time pattern, thus facilitating reintegration into the regular life. That is accustomed, the patients will they will be usual and regular to their 8 a.m. to 4 p.m. pattern. So the social integration into community life would be easier. And there was no absolute requirement for a highly qualified therapists to run the program. It was run by occupational therapists with inputs from psychiatrists and psychologists in mental health center. And interpersonal conflicts occurred as the clients grew closer to each other and functioned together. By employing pragmatic interventions, these conflicts were resolved. The pragmatic interventions means the quarrels between the patients, any interpersonal conflicts are addressed by looking into the cause of the problem and by dealing it in a reality approach. And similar structured daycare program can be adopted to other Indian settings to help close the mental health care equity gap among socially and economically disadvantaged. Proper planning, support, and structuring of the program can ensure sustainability of the program. Daycare programs can help persons with severe mental illness to reintegrate into regular life into society. And thank you.
Questions?
Doctor, you said you kept a patient from morning till evening. huh?
Yes, sir.
So, what was the program they were given?
Sir, yeah, that's in daycare program. Actually, it runs from 8 a.m. to 4 p.m. Sir, it includes mainly the participation of the patients. It includes vocational training and their assessment, group activities, leisure activities. They will be engaged in some kind of recreational activities, and we will be finding out if there is any individual skills of the patient. And if it is possible, we will be channelized into some kind of social skills, so that after the completion of the program, they would be going into some kind of employment, some kind of gainful employment, sir. So the caregiver burdens will also decrease once they are attending the day-to-day care program. And the treatment adherence, it will be also monitored by our occupational therapist, sir.
How long usually they continued this daycare?
Sir, actually, it does not involve a specific period, sir. Once we are actually fine-tuning them with respect to their individual skills, and if they are getting employment in some kind of work, they will be going there. And for treatment-related, medication-related purposes alone, they will visit the hospital on OP basis, sir.
Thank you.
Thanks.
Thank you. Abhijit?
Good afternoon and Johar everyone. Today I'm going to share our experience of working in strengthening care for rural patients with type 1 diabetes in 2 district hospitals of Northern Chhattisgarh. My name is Dr. Abhijit Gadewar, and I come from an organization called Sangwari. We are a group of health professionals with different clinical backgrounds, but we became a generalist over last few years, and we work in northern part of Chhattisgarh. It's called Sarguja, and our core areas of work are, we have 3 primary health clinics, then a community health program, then we have active health system support activities, which includes addressing severe NCDs, pain and palliative care, and then capacity building and mentorship of health system. Then advocacy to a certain extent. So, so when you see the type 1 diabetes, it's not so prevalent, and when we see in the rural areas, it might be even rare. So there are some issues which prompted us to work in type 1 diabetes. Is they are like it causes catastrophic expenditure, especially in rural families. Then mostly children and young adolescents, they suffer the disease, and they are vulnerable. Then health system are well equipped, are optimally equipped with to treat type 1 diabetes, but their capacity to treat is somewhat questionable. And importantly, this quote sums up our understanding of working, why we want to work in, why we started working in type 1 diabetes is like population level analysis comes from individual level understanding, and it can subsume that individual level experience of disease and impairment. So, and even most of you, if you have been involved in the clinical activities, you might have seen the patient with similar illnesses might express the disease in a different way. So the patient coming from a rural or even the Adivasi areas, they might express the disease in a different way than the urban their urban counterparts. And last but not the least is there are some equity concerns which encouraged us to work for type 1 diabetes. So there are few patients, like a girl who is a school going, she has to get down 4 kilometers from her hilltop home, and then she had to travel 10 kilometers to get a bus, and from the bus then she can go to district hospital where she would get insulin. Then there is a girl who left her schooling from the ninth class, and her father found that he has to feed many mouths in the home, and they lost all the hopes to take care of their daughter and to treat her. And there is one guy who is around 21-year-old, who has no kind of social support. The family are so vulnerable, they are not even in a position to take care of their son. So these are some issues, these are some expression of type 1 diabetes which we saw in rural patients, which you might not encounter the extent of severity you might not encounter in other parts. So that's the correctable inequity which we are talking since morning. How we are going to manage that at the level of rural healthcare? So there are different layers of rural healthcare when it comes to treating severe NCDs. So the rural healthcare itself is a challenging field, but when these challenges get multifolds, when you see the complexity of diseases increases, and type 1 diabetes is one such example. So the rural healthcare is a complex, but when you unfold the further layers, when it comes to child healthcare, it's mostly limited to immunization. When it goes down to non-communicable disease, it's a huge current and future challenge in front of the health system. And when it comes to pediatric NCDs, frankly, we don't have much idea what is going to happen. It's so the field is still in the dark. But despite that, we did a quantitative assessment of these two district hospital and some multiple interactions with the stakeholders. So we draw we understood some gaps and challenges. So one is, we found there is no proper care of severe NCDs such as type 1 diabetes. We found optimum availability of the insulin, different types of insulin, but they are not being used adequately. When we asked to the district hospitals to give a list of patients whom they have identified the type 1 diabetes, they could produce only a list which having 8 to 10 patients, and most of them, they don't have any the address, contact details, none of it was there. They did not have any previous records of investigations, what type of insulin they are having, what dose is they are taking. There is no record of HbA1c reports, whether it is how the trend was there. We couldn't follow that. And there is practically no system of follow-up mechanism, because they don't have any record of tracking. They don't have any contact details. So there is no system of a follow-up mechanism. Even families, they were never counseled that how that should be taken care at the home. And none of them were given glucometers or strips to measure glucose at the home, despite it is available in the system. So these are just broadly some gaps we identified, and based on these gaps, we thought 5 these strategies on which we thought we should work. So one is a team of care coordination or the proper coordination and patient navigation, training material and developing protocols, then making supplies available, then patient education material and stuffs, then creating a proper linkage, upward, downward, and downward, upward, both ways. So these are 5 strategies which we thought we should focus on, and based on that, we devised few interventions. So I'm just going to enlist it, just going to read it, and then we can go a little detail further. So training of the medical officers, including mentorship and hands-on training. Then making available supply chain, as I said, most of them are available, but they had to bring into the circulation, bring into the use. Establishing a registry at the district hospital, then making available patient booklets, then some easy to use ready reckoner materials, establishing a care coordination team, and most importantly, we focused on home visits. So these are the training has to happen in a case-based manner and hands-on training. These are some materials which we developed. On the left hand side, it's a easy to use ready reckoner for the medical officers who are sitting in the district hospital OPDs. This is the kit which we can give to patient for monitoring glucose at home and maintaining record of it. If we see the outcome, we could now enroll around 70 patients, close to 70 patients by the end of October, with fair amount of HbA1c control over these last few months. The coverage of patient has been increased in equity-wise indicator. The majority of patient are female, majority of Adivasi, rural. If you see, like more than half of the patient, they don't have fridge at home to store insulin, and most of them are more than 67, 60 are from adolescents. So, so the few learnings which I just want to highlight are that creating some tools can help us to demystify the care of type 1 diabetes, to train the medical officers, and that care can be implemented at the level of district hospital, and gradually it can be decentralized to the community health centers also. So the active support to health system can bring care for the severe NCDs such as type 1 diabetes, and it can practically benefit to the people from rural areas. So I want to thanks to all of the, it's a whole teamwork which I want to thank. Thank you so much.
Queries and comments?
Was there any screening of the percentage of the population affected by this type 1?
Pardon, sir, screening. So these were identified in the district hospital itself. So the patients who were identified at the district hospital, we supported them to connect with the team of coordinators, and so there was no active screening in the hospital. These were identified in the hospital. Sometimes they get admitted because of decay or some other illnesses. So there was no active identification of the patient, and the patient who are already identified in the community. So they get connected with the district health system, because the people working in community health centers or sub centers, they would know that there are a couple of children or patients who are having diabetes and who would need insulin. So they would call us, the team, the coordinator team, and then we would coordinate connecting with the district hospital and initiating the treatment and following up the treatment.
This is more than the national average.
Pardon, sir?
The percentage of affected people, is it more than the national average?
There are no definitive studies of the prevalence. It can range from 1 in 10,000 to 3 in 10,000. In urban areas, it can go up to 3 in 10,000 population. Thank you. So for type 1 diabetes, so currently this work is going in 2 district hospitals, actively in 2 district hospitals, but the technical support or training, it is happening in 4 additional district hospitals also. So totally 6 district hospitals we are covering in terms of technical support, but active support is in 2 district hospitals. The population coverage is around 16 lakh, so 1.6 million. Thank you.
A very good afternoon to one and all. I'm Dr. Das Prakash, and I represent Mahatma Gandhi Mission, Aurangabad. So I will be sharing an enriching experience of benefits of a residential community training program or postgraduate physiotherapy residents in underserved rural and tribal areas. To begin with, I think most of the people might be knowing about the SEARCH, Society for Education, Action, Research and Community Health, based in Maharashtra, Gadchiroli, one of the Naxal districts of Maharashtra, which was founded by Padma Shri Dr. Abhay Bang and Rani Bang. And then I represent Mahatma Gandhi Mission, which runs a medical college and a physiotherapy institution based in Aurangabad. So this SEARCH is an NGO which provides healthcare services to more than 134 tribal and rural villages, covering a population of 10,000 people. 7 community-based population studies in tribal and rural villages in Gadchiroli district was conducted by Search, and then the study concluded that there's a prevalence of pain in back, in and upper and lower extremities was a significant health concern in all these rural populations. This is because of the agrarian workforce with extensive physical labor, lack of knowledge, and awareness of appropriate treatment. For all these kind of pain in upper and back, pain in back and upper extremities and lower extremities, physiotherapy intervention holds a promising intervention in limiting the disease progression. And then there is acute shortage of physiotherapists serving in rural areas remains a challenging issue. Let us see the trends of this PBE, that's a pain in the back and extremities. So again, the study conducted by the Search concluded that the medical consultation cost rupees 31,440 rupees per village, and this only the consultation component. And then when it comes to purchasing medicine, it costs around 4,20,602 per village. And then because of this pain in the back and pain in the back and extremities, it also cost a loss of 12,103 working days in these villages. These people here a very meager amount because of this pain in the back and upper and lower extremities. They lost this 103 working days, and then the estimated cost of these work days lost per village is rupees 12.10 lakhs per village. So these are all the studies published by the Search. And then, so these tribal villages, there's a concept called as a tribal health assembly. In colloquially, they call it as a tribal laga. So we had an opportunity to attend one of these tribal lagas, and then they said that the pain in the, particularly in the back and the extremities, one of the major concerning problem. They are limiting these to go into the work into the agrarian sector or whatever the sector it might be. So this is one of the main concerns for all this rural and tribal population. And coming on to this physiotherapy intervention, according to the Maharashtra State OTPT Council, there are 11,900 registered physiotherapists practicing in Maharashtra. And then there are 91 physiotherapy institutions in Maharashtra. And then all these people are practicing trends only in urban and semi-urban areas. So none of the very few people go into the tribal and rural areas. So how do we want to bridge the last mile? And when we see the India trends, so the World Health Organization recommends there should be at least 10 physiotherapists per 10,000 population, whereas India has only 0.59 physiotherapists for 10,000 population. And when we say the South Asian average, it's of 1.59. So where is the scope of practicing physiotherapy in the rural areas? Should we ignore the rural areas and tribal areas? So we understand the Mahatma Gandhi rightly said, the future of the country lies in its villages. So how we going to address this tribal population and rural population? So I would like to share our enriching experiences of how do we bridge this gap along with the Search, reaching the unreached. Our Mahatma Gandhi mission runs a postgraduate program, and then it's one of the most reputed institutions. And then we had an MOU with this Search, and then we depute our first year postgraduate residents of 5 weeks at Search. That's called as a residential community training program. So we started this flagship program in the last August 2022. And then till now, 33 postgraduate residents were posted in the 12 batches since August 2022. And then they provide comprehensive physiotherapy services in and around Gadchiroli through Search. And then they address the acute shortage of physiotherapists in rural and tribal areas. And then they also work with the Center of Joint and Spine Health. This has been specially created by the Search to address this PBE in the tribal areas. And then we also work with the physiotherapy OPD and IPD services at the Search Hospital. And then we have exclusive mobile medical unit and then mobile physiotherapy unit. And then we also conduct outreach camps in the villages. And then we also provide services after surgical camps, after spine surgical camps, general surgery and plastic surgery camps. And then when we had after the 1 year, when we had a review, and then our postgraduate residents on a typical day, they treat 31 patients. And then on a 1 year, we have treated around 9,300 patients by PG residents in 12 months. So we have a comprehensive assessment, and then we also have a evidence-based physiotherapy intervention. Also we do the, and then we also had an opportunity to work with the Spine Foundation, which was founded by Dr. Sekhar Bojraj. This team from Mumbai, they come to Gadchiroli every three months once, and then we conduct a surgical camps, and then our physiotherapy residents also provide post-operative rehabilitation to that. And then we also had an opportunity to work with Dr. Gauri Kinkre. He heads the rehab team of India. And then in 1 year, we have treated around 105 patients, post-operative surgical patients in the tribal Gadchiroli district. And then when a feedback has been collected, if structured feedback was collected by all the students, by the postgraduate residents, and then 62% of the postgraduate residents said it's an excellent learning program outside of a classroom, outside of a clinical setup. And then it provides an experiential learning of people working in the community. And then 38% of the people said it's a good learning program. And then 100% of the postgraduate residents recommended this to the future postgraduate residents. And then we are continuing it for another 2 more years. And then this residential community training program enhances their ability to adapt to rural healthcare settings. And then the most important insights and clean learnings are it bridges the healthcare gap in the rural and tribal areas. And then it provided us an opportunities to work with the experts, in the public health experts. And also we had an opportunity to work with the Spine Foundation and the RIA Foundation of India. And then it also contributed to the successful rehabilitation of 1,000+ patients in the remotest corners of the country. And then some unique learning experiences working with this rural and tribal community. And then this physiotherapy is used as your potential opportunity in the universal health coverage. So physiotherapy can able to limit the disease progression. It can able to limit the surgeries. We can able to prevent further disabilities and complications. And then way forward, the postgraduate institutions should implement similar kind of residential programs to the residents. For example, we have 34 postgraduate residents in Maharashtra. Once this program is implemented, so that there are several thousand rural patients will be getting benefited, and then physiotherapy interventions can limit the disease progression. And then this also reduces the out-of-pocket health expenditure and reduce the health economic burden and instills the spirit of community service among the residents. And then to conclude, of all the forms of inequality in healthcare is the most shocking and inhuman. Thank you.
Hello. So the students go to the villages. So how would they manage without equipments and machineries in the village, and how they are trained, how they cope up? Because in the college, every setup is there. So how you prepare them to work in such place where there is maybe no electricity and no Gadchiroli and such? So
yes, sir. So when this idea popped up in our mind, and then people from Maharashtra know Gadchiroli is a place known for punishment postings. The people from Maharashtra say when they're going to Gadchiroli, it's a punishment posting for you in an Axel area. And then I head the Department of Community there. And then I said that I want to post my students there. And then people are very much apprehensive. And then I said that why? Let us go. What we did is, as my head of the department, I called my principal and then I called my deputy registrar. We three went there to the search. And then we had a collab. We just saw. We spent 2 days of our time in the search. So what they do actually, how do they do? Is it safe for our students and residents? And then we were convinced. And then we came back and then we gave a presentation with the videos, with the formal presentation. And then they also have a setup of called as a mobile physiotherapy unit. And then where they have a very packet machines, tents, which is a packet machine. It's a compact machine which can be runs on a batteries. And then we have a mobile stimulator and then mobile physiotherapy unit. And then we worked on that model, sir. We worked on that model. And then we gave a presentation. People were really convinced. Okay, let us go for that one. And then when the first batch of the residents went, they gave a very positive feedback. They said that it was wonderful learning experience in the search, because apart from learning in the tribal community, the search has a concept of a knowledge circle. So every Thursday, there will be people from a different walks of life. So there will be visitors from all across the world coming and spending some time there. They talk about their experiences. That's a knowledge circle. And then we have Ramadan. Every weekly twice, they have a volunteer. They want to do some kind of a physical activity, just cleaning or weeding, all those things. They want to contribute something. And then daily evening, they have interfaith religious prayer meetings. So where Dr. Padmashri, Dr. Abhay Bang and Ronnie Bang, they talk about harmony. There's a lot of learning happens apart from those things. So really students enjoyed a lot, enjoying a lot. So this is how it took away, sir. Yeah.
You know, in India, in rural areas, there used to be traditional massager.
Yes.
Did you find anything like that in your study?
Yeah.
And how the people responded to your kind of treatment?
Yes, sir. So typically what happens when it comes to back pain or some kind of a pain, so there was one kind of a traditional practice of herbs, herbs, and then they just apply it with the oil and then they apply it over there. And then it was very difficult for us to convince them. But a search with the 30 years of experience, search as a good reputed name in the tribal society. And then when a people from a search comes and tells, oh, this is gonna cure you, so it was very easy for us to get into the people, so that people really appreciate it. When we give this kind of electrical models like a TENS or IFT, so they got some kind of instant relief, and then they started accepting our things. And then slowly we are working of like ASHA workers, we also have a concept of Arogya Doots. So every village has a kind of one identified person, and then we are training them to identify red flags, and then referring us for the spine surgeries to Dr. Shekhar Bojraj. Thank you, sir. Thank you.
Last presentation. Abhara.
Hi, my name is Abhara, and I'm presenting on behalf of my colleagues with work done at the Ramalinga Swamy Center on Equity and Social Determinants of Health on the role of medical education in the provision of respectful maternity care. Historically, attention to women's health has often been around issues of controlling fertility or controlling maternal mortality and morbidity. And over time, due to both secular changes as well as a rise in institutional deliveries, both of these concerns have, I'm not totally under control, but they've come a little bit under control. So now attention has shifted to the kind of care that women receive in the context of institutional deliveries. We know that the quality of maternal care is fairly questionable in many parts of the country. And we also know that women's concerns about mistreatment and over-medicalization during labor and delivery can be a barrier to institutional deliveries. So in order to understand this situation better, we need to understand women's interactions with providers, with institutions, with health systems, and so on. This mistreatment and abuse in the social sciences, I'm a social scientist by training, we call it DNA, disrespect and abuse. And disrespect refers to biased normative judgments about women. It refers to physical and verbal violence. Abuse refers to the use of non-evidence-based obstetric procedures. Studies have established that there are structural factors that lead to DNA, such as patient loads and infrastructural restraints and so on, and also socio-cultural factors such as hierarchies between patients and providers and so on. DNA is a human rights issue, it's a public health issue, and it's an equity issue. There's a lot of researchers who propose that medical education probably plays a role in DNA, but it's been relatively understudied in the context of India. Very few studies have been conducted at all, mostly in South America. There's two components to medical education. The one is the first part, which is the classroom teaching. So this is largely based on the formal curriculum. And currently the curriculum, even with updates in more recent years, does not really include any references to disrespect and abuse or respectful maternity care. It doesn't even include many references to issues that might have a bearing, like socioeconomic inequalities or gender inequalities. And there's been some changes in this direction. The EdCom model, which was implemented by the NMC over the last few years, has made some steps in this direction, but research from Central America and South America suggests that it might not be sufficient to alter obstetric practices. The second part of medical training is the practical training. So what happens in internships and residencies. So it's how students become actual doctors. Here too, the research suggests that, hierarchical training structures, supervisory practices, and so on can inhibit respectful maternity care. And once again, the sort of the power hierarchy between patients and providers can be dehumanizing environments for the women who seek care at such facilities. Medical education regulations in India largely focus on infrastructural and human resource constraints and less so on other factors. We conducted our research in two large public teaching hospitals, both 24/7 tertiary care facilities. I put 20,000, but my colleague reminded me yesterday that it's over 25,000 deliveries annually. So highly overloaded. They were about 4x patient load as what the hospitals could reasonably support. We conducted interviews with providers at all levels of the obstetric facilities, of the labor wards, from nurses and interns and residents all the way to unit heads, which we roughly divided into those who are finished their medical training, senior providers, and those who haven't, which are medical trainees and nurses. This was part of a larger study on disrespect and abuse. So I'm just going to talk about the portion that pertain to medical education. So we had the codes on the left, which had directly to do with education. So this was curricular things and what was happening in labor rooms in terms of instruction. And we also looked at factors which reasonably had an impact on disrespect and abuse, so institutional factors, perceptions of patients, and health system factors. We arrived, through qualitative analysis, we arrived at 4 sort of pathways through which we felt medical education played a role in DNA. And I'll go into detail in about each one of these. So the first one was unequal power relations and hierarchies. Some of this is structural relationships between providers, and this is necessary to run a clinical unit. Obviously, there have to be clear chains of command and clinical decision-making and ultimate authority and so on. But what we find is that junior providers who might have some say on the matter didn't feel comfortable speaking up. So, in a very high stress environment, they didn't necessarily feel like they could question senior providers. And so they're taught in their classroom that, you shouldn't use certain procedures, but then they see it occurring routinely in these labor wards. And the other aspect of this is the provider-patient relationship, which is the hierarchy between patients and providers. And, because these women who came to these clinics and hospitals were typically poor, of low caste, of limited literacy, and they were receiving free services, a lot of faculty members and a lot of medical students seemed to think that it was okay to use this as a learning opportunity and not necessarily in service of the woman. And there's also this sort of attitude in the way they treated them, which had less to do with being empathetic, but more to do with being efficient or effective. And neither patients nor younger providers felt like they were in a position to challenge these hierarchies. The second one is the prioritization of clinical outcomes and instruction. The focus on instruction meant and the opportunity to learn new clinical skills meant that women were sort of not centered in the provision of maternity care. And students were also assessed on clinical outcomes, essentially preventing morbidity or mortality, and they were not assessed on the way they provided interpersonal care. So there ended up being this focus on the provision of clinical care to the exclusion of other forms of care. The third one is the limited presence and supervision of senior providers. Routine deliveries are typically managed by the junior providers, and senior providers tend to step in when there's some sort of complication or an emergency. And dealing with that requires protocol plus experience. But because junior providers rarely saw senior providers delivering routine cases, they tended to undermine the value of protocol, as that first excerpt suggests. And senior providers seemed to know that this was happening, and they said it is happening. These are very busy wards. We can't possibly monitor everything, but also didn't feel like it was something that they necessarily needed to address. The final pathway is, the learning. As I mentioned, senior providers tended to step in when there were, complications which led to surgical or instrumental interventions. So junior providers learned routine provision of care, normal deliveries from other junior providers and the nurses. And the nurses might have been experienced for sure. But at the same time, they learned procedures rather than the rationale behind doing certain procedures, or understanding when to use them judiciously. And it was a source of frustration for a lot of students because they felt like, one of them said, I'm just working like a donkey. I want to know why we're doing what we're doing, and there's nobody here to explain it to me. And they appreciated what the residents and nurses were teaching them, but they really wanted more. So I just explicated 4 pathways through which, medical education can lead to, can actively lead to disrespect and abuse, or can at least limit the provision of respectful maternity care. There were some, I shouldn't make it sound all doom and gloom. There were certainly some faculty members who stood out as role models in the faculty. These were, people who sort of broke down those structural hierarchies. So they made themselves accessible to the junior providers, answered questions, were kind and empathetic in the way they treated the women who came to these hospitals. They did, they took the time to sort of work with people to explain to them what was going on, and they were present. So under their supervision, you often didn't see unnecessary procedures like, routine episiotomies or fundal pressure. I mean, it goes without saying that all of this is only possible if the intense patient and workload is mitigated. Given the crush of patients, it's very hard for providers to provide the personalized care that women need. Lakshya and EdCom, Lakshya is a labor room quality. It's an infrastructural improvement initiative. And I mentioned EdCom. These are great changes, but our research suggests that just infrastructural and curricular changes will not be sufficient to make the change that we want to see. And our study suggests multiple points of intervention. Thank you so much. Oh, that was a quick hand. Yes, absolutely, absolutely. So both of these were tertiary care hospitals in a very large city, and they should not be. And this points to a failure of the public and of the primary and the secondary healthcare systems. That leads to an explanation of why these patients all end up here. In fact, as a follow-up to this study, we did actually conduct studies in PHCs, CHCs, maternity care hospitals at all levels, in district hospitals and so on, to sort of understand what were the factors that led to these referral patterns, and what were the referral patterns that were going on and led to this intense crush of patients at tertiary care hospitals. It is definitely the first step that we need to attend to. Yes. Thanks. Yes.
So there is some kind of background relation that we are giving to myself with this kind of thing in neighborhood. Because we can take this amount of facility than required. This amount of facility can cause side effects, or it may cause any harmful effects, or it may not be needed because
absolutely, we saw that over and over again. I mentioned episiotomies and fundal pressure, but the denial of pain relief was something that we saw very commonly. And this was specifically an equity issue because a lot of providers had judgments about which kinds of women needed and don't need pain relief. So they often thought rural women, because they're, they do heavy labor, that they might not be in need of pain relief, or Muslim women, and these are all excerpts from our interviews, that they've already had 4 or 5 babies, they can do this without any more babies, regardless of whether she'd actually had those babies. So not only was it a frequent thing that we saw, the denial of pain relief, it was also very targeted certain disadvantaged groups.
I say disrespect and abuse is a result of lack of infrastructure and manpower in the government public hospital. Do you agree?
100%.
What are your suggestions for that?
No, I think, and this is where I think, as a social scientist, I was a little nervous presenting to a group of doctors. There are interventions that suggest, these are minor and we've not had a lot of them in India, but there are interventions that suggest that even minor changes that we make in the way doctors can talk to women, and this was conducted in AIMS, so it's a fairly busy hospital, I suppose. Even things like calling the woman by her name. What we observed during our fieldwork was that they'd say, "Ha, that woman in bed 33." Like that was even saying, "No, go talk to Gangamma," for instance. That itself made a difference to the woman. It didn't take much additional effort, but it made the woman feel much more respected. So there are minor interventions certainly that we can do. And I think a more major intervention would be, as she pointed out, was to sort of tackle the referral systems downstream to prevent this overloading of patients in tertiary care facilities.
Thank you.
You're right. This is a problem in all large public hospitals, teaching or otherwise in India, which is that patients, especially patients who are coming to government hospitals, are disadvantaged in many ways. We did not conduct our research in any other ward, so I don't have a comparison point. But once again, research conducted in South and Central America, which is where a lot of this comes from, suggests that women are nevertheless disadvantaged even within health systems that are otherwise disadvantageous. There are notions, as he pointed out, about their ability to tolerate pain. There are people have judgments about their level of education or understanding. They might talk to the husband rather, or the father-in-law rather than the woman herself. So I think there is a lot of reason to suspect that that obstetric wards are especially sites of disrespect and abuse. I don't want to say it so bluntly, but of disadvantage, certainly disadvantageous treatment for women. Yes.
Ma'am, so you had talked about senior providers being more involved. So I wanted to know whether senior providers taking more hands-on responsibility in patient care translates to better care for women?
Yes. I mean, that's a very short answer, but absolutely yes. Even the nurses and the junior providers say that when the senior providers are here, they know how to talk to patients, they know how to care for patients and put the woman at ease. And I think that's something that the younger junior providers don't necessarily see modeled on a regular basis. The fact that there are some senior providers who fulfill that role and they're like, role models, they're widely admired by everybody. And you see these younger providers say, I want to be like that ma'am, or I want to be like that doctor, the way he talks to patients, the way she, explains things to them, I want to be like them. So I think it definitely makes a difference to have supervision by those kinds of senior providers.
My other question is based off of the question that was already asked. In other departments which are overcrowded, we do not actually tend to see as much disrespect and abuse, I feel. And when disrespect happens, when people make these dehumanizing comments towards women, it tends to be more based on the fact that they've been sexually active. Even married women who've been sexually active with their own husbands seem to be shamed in labor rooms. Like, these comments are pointed towards that one particular thing. So do you think that something like that is happening?
100%. I mean, I did put up some of the very crude comments, but certainly there are cases where, when the woman is, in pain in labor, the nurses would slap her and say, you didn't scream when you made the baby, and now you're screaming when you're trying to get the baby out. Like, they would very bluntly say these kinds of things. So there is a lot of judgment around their sexual activity, and their and once again, this is besides being a woman, if you are a Muslim woman, if you're a Dalit woman, if you're a rural woman, there was these additional judgments that were piled on too, because there's all these notions about their sexual behavior and activities and so on. Thank you. Thank you so much.
Okay. Thanks to the all presenters, because we have actually gone through from children with type 1 diabetes to women to elderly, and then different marginalized population. It is a nice opportunity to listen to. So those who want to have further interaction with the presenters, please make use of the coffee time.
I thank all the presenters. It's an amazing presentation, starting from Assam to Kerala and urban people to tribal areas, almost all sort of things. And when somebody talked about Assam, it is more or less a bonded labor situation. Coming to urban area in Trivandrum, it's one of the highly educated society, and we can see the difference. And the skill of the presenters should be appreciated. I thank all of them for the wonderful presentation. Thank you.
Thank you to all. Thank you to all the presenters. Thank you, Dr. Karunakaran and Dr. Arun, for moderating this session. We'll conclude this session and go on to the next session.